Good afternoon, and welcome to all of our attendees that are joining us for day number 2 of CaraConference 2020, HIV Now and Next. We'll be running this week through Friday, so welcome to day number 2, excuse me. So if you're feeling social, just like we said yesterday, please feel free to tag us and use hashtag CaraCon to have a wonderful conversation with us on our different social channels. We are at We Are Caracol on Twitter, Facebook, and Instagram. I do want to go over a couple of quick housekeeping notes before we get started here. For any technical questions that you have today, so if you're having any trouble with some of the functions of Zoom, please use the chat function. This is what it looks like for folks on desktops and laptops. And for any questions related to the presentation, that I will ask our presenter today in my role as moderator, please use the Q&A function. This is what the Q&A function will look like for folks on laptops and desktops. For folks on joining from their phone, this is what the chat and Q&A functions will look like from there. We want to give a big thank you to our sponsors, including our presenting partner, Maytech, the Midwest AIDS Training and Education Center, through the University of Cincinnati. Our other sponsors, Gilead and Theratechnologies, and our supporter, Grace Hospice. Support for today's CaraConference session comes from Theratech. Theratechnologies is a commercial stage biopharmaceutical company. We currently make prescription products in the US, Europe, and Canada. Our commercialized products and our research pipeline focus on specialized therapies addressing unmet needs in HIV and oncology. Thank you to all of our sponsors. So I'm going to turn things over to Caracol's Harm Reduction Specialist, Harm Reduction Service Coordinator, Billy Golden, to introduce our speaker for today, and I will be your moderator. Thank you.
Hey, everybody. Good afternoon, and thanks for joining us today. I am really excited to introduce our speaker, Tasha Turner Bricknell. Tasha and I met in 2016. I was working for Cincinnati's first syringe service program, the Cincinnati Exchange Project, and Tasha joined as a volunteer. She was amazing. She also really helped broaden my own understanding, specifically of how harm reduction fit into public health overall. And right now, Tasha is a board member of Harm Reduction Ohio. She's an assistant professor of clinical nursing at University of Cincinnati's College of Nursing. Tasha started harm reduction work in 2015. She's been an RN for 15 years. She's been teaching for 9 years. And I think that Tasha brings great clinical skills, always a very current knowledge of best practices, and a pragmatic and positive attitude to whatever work she's doing. It's been a real pleasure to know her and call her a friend. So with that being said, Tasha, thank you for joining us today and agreeing to speak. And I'm going to turn the screen over to you now.
Thank you so much, Billy. That's such a wonderful introduction. It's my pleasure to be here. I'm very happy to be here on this beautiful Tuesday to share this space with you and talk about two of my favorite subjects, harm reduction and rural health, and how at this unique point in time, the intersection of those two is really important. I want to thank Caracol for having me, and what a great conference idea. You can always count on Caracol for being innovative and find a way to be able to bring us all together in a meaningful way, even though we can't be together in person. At this time, I'm going to share my screen with you guys. Bear with me for just a moment. I'm going to move this if I can. Do this. There we go. and make this a little larger. All right, so we're going to talk today about the changing landscape of harm reduction outreach. And that, to talk about the changing landscape, it really has kind of two meanings to that word, both literally and figuratively, and we're going to talk about that a little bit. So today's objectives, we're going to define harm reduction. Harm reduction is a term that we hear a lot in public health now, and that's a good thing. It's really become a part of our, our national vernacular, and that hasn't always been the case. So, but sometimes when the term is used, it's not quite right. So let's talk a little bit about what really does it mean, what is its origin. We're going to identify the intersection of drug use and infectious disease, talk about populations at risk for HIV and hepatitis C in the rural areas, identify potential barriers to care, and strategies for building partnerships and strategies for outreach in those rural communities. So I want to first start off by thinking about, what do we know? What are our perceptions of rural health? I know we have a wide variety of backgrounds and knowledge base in the audience. Some of you may have been doing rural health for quite a long time, and some of you may have a primarily urban-focused practice. So let's just ask ourselves some questions, and then we're going to talk about these later and see how we feel about our responses at the end of the presentation. So the first one, substance abuse is more or less common in rural or urban areas. Rural communities have more resources for health and social services compared to urban communities. In rural areas, people who use drugs are less likely to inject drugs. Non-urban counties in the southeastern United States have a higher HIV prevalence than most large US cities. Would you say that that is true or false? So think about that, and we'll poll those questions. Zoe will poll those for us, and then we'll talk about that again just a little bit later.
I'll keep the poll open for a few more seconds, and then I'll go ahead and close it, and then we'll discuss things later on as the presentation goes on. Right, so far, it looks like just over half of our participants have voted.
All right, perfect. And I know that
All right, I'll go ahead and close the poll here and hand things back over to you.
Thank you. All right, so starting out, let's talk a little bit about harm reduction. So what is harm reduction? You often see it defined as a set of practical strategies and ideas that are aimed at reducing the negative consequences associated with drug use. That's from the National Harm Reduction Coalition. It's important to also remember that harm reduction as a movement is about social justice, and it's about respecting the human rights and dignity of people who use drugs. I think sometimes in our discourse, especially in the United States, but in a lot of different places around the world, we really forget about the human rights of people who use drugs, that they still have the right to be treated with dignity. And the harm reduction movement was really about advocating for that dignity, respecting that dignity when we see it, and supporting it in a non-judgmental way. It does not ignore the danger that is associated with illicit drug use. I'll tell you a little bit about my personal background. I am from Northern Kentucky, but my parents are from Appalachia. I'm the first person in my family to go to college. My parents are very nice people, but I'd say they're very kind of typical Appalachian Midwesterners. And when I first started doing this work, the knee-jerk reaction that I would often get from extended family would be two things. One, you're telling people that it's not dangerous to use drugs. And of course, the second one, which is that you're encouraging drug use. And neither is the case. The harm reduction movement, we're not saying that there isn't a danger associated with illicit drug use, just the opposite. We want to get out face-to-face with folks right where they are, just as they are today, and talk to them frankly about the dangers associated with drug use so that they can make movements and behaviors to protect themselves from that risk. But I think it's really important to continue to remember that it is a social justice movement and that people who use drugs should be at the center of it. I hope my slides are showing okay. I'm having a little bit of trouble there. So let's talk a little bit about the intersection of drug use and infectious disease. So, it's no different. This is something that's not different in the rural community as it is in the urban community, but just to set the stage for our discussion, as we have more drug use in communities, we also have certain high-risk behaviors that lead them to be more at risk for infectious disease. So syringe sharing, syringe reuse, syringe-mediated drug splitting, that's when you're using a syringe to maybe prepare drugs that will be used by several different people, the sharing of injection materials, and then of course there's also high-risk sexual behavior that comes into play with drug use as well. We have intimate partner relationships, which can put people at risk for intimate partner violence. And then there's also people can be at risk for sex work as it is related to their drug use, and they can be at risk for intimate partner violence, interpersonal violence that is associated with that as well. And all of these put the person at risk for infectious disease such as HIV, hepatitis A, hepatitis B and C, endocarditis, soft and skin and soft tissue infection, often referred to as abscesses by our clients, which can relate in osteomyelitis, which is an infection that is in the bone, joint infection, and we also see increased rates of other sexually transmitted infections other than HIV. So, what really puts rural communities at risk? Hold on just a moment. I feel like we missed a slide. Slide 5. Let me try to see. Okay, yes. All right, I'm having some technical issues, so you guys try to bear with me a little bit. It looks like the photograph that I had attached here didn't load, which is fine. I apologize for that. So let's talk a little bit about drug use in rural America. Some people would say that it's not a new phenomenon, but there have been certain trends and certain things that have happened that have contributed to kind of where we are today. So one important thing when I look at the rural communities, especially here in Southwest Ohio, I really see decreased economic opportunity. And of course, with that comes increased poverty. Many people will say that rural communities in the United States have not recovered from the economic catastrophe of 2008. I think starting in the late 90s and through the early 2000s, we saw a decrease in the type of working class jobs where people really lived a sort of middle class life and made a decent living. We really saw them decline in the late 90s and early 2000s. And then with the economic fallout of 2008, the rural communities really hadn't recovered, and we still see that decreased economic opportunity there. We also are still seeing the ramifications of the overprescribing of opioids that occurred in the 1990s. It's really not a debate at this point that there's no question that opioids were being overprescribed in the 1990s and even into the early 2000s. In 2010 and 2016, we see heroin-related deaths in the rural communities in the United States and Canada increased by 400%. In 2015 and 2016, we see synthetic opioid death rates double. And then in these rural communities, what the research is telling us now, today, is that people who use drugs in the rural communities are more likely to inject than people in urban communities right now. And that's something that is a little bit of a change. I think, 5 years ago, even, we talked about how, rural communities were still using a lot of prescription drugs, and we weren't seeing as much injection drug use in those communities, but that's really not what we're seeing now as the case. Additionally, in the state of Ohio with COVID-19, we're seeing a real surge in overdose deaths. Right now, as of this morning, we've had 2,586 confirmed overdose deaths in the state of Ohio this year. That's such a tragedy, to know that there is naloxone available and that that these lives are lost permanently. These people they didn't overdose and were saved. These are overdose deaths. And, if we continue at the rate that we're going now, by the end of 2020, we will have the highest overdose death rate in the state of Ohio that we have ever had. And that's astounding because I think a lot of us in public health feel like we've made real strides in saturating communities with naloxone and really making inroads to have that life-saving medication available. But I think that this really just tells me that there's so much more work to be done, and there are people that we're not reaching. So let's talk a little bit about what puts rural communities at risk and who is at risk. So rural communities, we do have a decrease in health services. This map from the Rural Health Information Hub gives us a nice visual of where primary care, mental health, and other types of health services are mapped out along the state. And you see a lot of areas where there's really nothing for quite a radius. So we do have a decrease in health services, which does put our communities at risk. There's decrease in primary care, mental health, and also medication-assisted treatment for those who want it. There's also what I refer to as an interrelated web of causation. We have that everywhere, right? I mean, of course, we, if we're working in a big city, an urban setting, we still have that kind of interrelated web of causation, meaning groups of people who are, maybe partying together, sharing injection equipment together, having engaging in sexual behaviors together. In the rural area, we see, because it's these smaller communities, that tight-knit group of people who are using together, and it really seems to span out into, when you connect all of the sexual relationships and then layer on top of that the drug use and those relationships that are associated with sharing it can really expand out and include quite a lot of people per capita when you think of how sparsely populated the area is. So HIV in rural areas. So what this comes from this article, Schaefer, that talked about really looked at what we're seeing with HIV in both the rural areas of the United States and also in Canada. And so people who have less access to HIV testing, we're seeing that people who are diagnosed with HIV are being diagnosed at a later stage. There's a later initiation of drug therapy, and of course, an increased HIV mortality. We do find when we talk to folks that they feel that they experience an increased stigma associated with their HIV status in the rural communities as compared to urban communities. And then, of course, the challenges to access care, significant challenges related to providers being available, access to providers and the provider shortage, and then also things as simple as transportation. And we're going to talk about some of those things as well. So some people will say, who've been working in the rural communities for a long time, that there has always been drug use in the rural communities. They've always had alcohol. They've always had certain types of drug use. But so some people will say that we have underestimated. We have a history of underestimating substance use in rural communities. Sometimes rural communities are kind of idealized, but in reality, there's a really stark difference between the haves and the have-nots in rural communities. I notice just when I'm out driving around through some of the southwestern Ohio counties that it seems like there's a real disappearance of the rural middle or working class, that you see, really big homes where people seem to be quite affluent, or people who are really struggling to make ends meet. So we really need to help people understand who's at risk. So I think that not only do we as healthcare providers and public health experts have historically had a tendency to underestimate the risk there, I think also people who can live in those communities, stakeholders, politicians, community leaders, people who work in the schools and families, can have a tendency to underestimate their own risk. So I think it's important that we provide education to those folks, to try to meet with stakeholders and help them understand that, their community is not idyllic. No community is, right? And how drug use and the opioid epidemic has placed them at risk for HIV, and that they need to understand that so that they can protect themselves, their families, and their communities, and have healthier communities. And then, of course, getting education out to youth is vital so that we can help youth understand what their own risk is so that they can change their behaviors to protect themselves. So some barriers to care in the rural setting, not that different than any other setting. I think it's important that we remember Maslow's hierarchy of needs when we're setting out to reach these communities. I'm not going to be effective if I go out into a community and I try to talk to them about getting into medication-assisted treatment when they don't have safe place to live and food to eat. So what we're seeing right now with a lot of really effective programs that are responding to the opioid crisis in rural communities is that they have interventions in place to address food scarcity and housing insecurity. I know that you guys for a long time are familiar with that housing first model, right? So, that's really based on Maslow's hierarchy. If somebody doesn't have, a roof over their head or a place to lay down tonight, then I'm not really going to be effective if I try to talk to them about condom use or whether or not they need harm reduction supplies for injection. And then, of course, like any other community, there's also that intergenerational trauma. And I don't want to imply that that's, unique to the rural setting, but I think we do need to remember that it's there. At this point, the opioid epidemic has been going on now for almost 30 years. So we have generations of families who have struggled with substance use in their family, who have had loss, who have had negative experiences with the healthcare setting. They've had negative experiences with incarceration. And the trauma that has resulted from those experiences is profound and long-lasting. And we have to really be aware of that when we reach out to those communities. So barriers to care, talking a little bit more about these barriers, you'll notice that I have criminalization at the top, and I'll tell you why. I think that we always talk about stigma, stigma, we want to reduce stigma, reducing stigma. Well, sure, yes. But let's peel back that stigma onion a little bit and talk about where that stigma comes from. A lot of people that I talk to in the rural community, not just I talk to average folks that are stakeholders and live in the community. I've done some focus groups in the correctional facilities and talked to folks who are on the other side of the criminal justice system related to their drug use, and also healthcare providers and people who work in the hospital setting. And when I really start to peel back that onion of stigma, criminalization is at the heart of it, because most of the people, now occasionally you'll find someone who doesn't believe in any kind of stimulant use. They don't believe people should drink, they don't believe in alcohol, but that's real rare. What's more common is that a lot of people believe that because what the person is doing is illegal, that they should not help them. And by not help them, they mean that society should not help them, that we as a people should not have interventions in place to reach out to them. They should not be saved with naloxone. They should not be provided with healthcare, et cetera, because what they're doing is illegal. So it's this, I think that over time, and it's been exacerbated by the war on drugs, we're really into crime and punishment here in the United States, right? Of course, not all of us, but as a society, there's this message that is, what you're doing is wrong and you need to stop. What you're doing is against the law and you need to stop. And I think that really contributes to the stigma. So I think that, as advocates, we do need to start to chip away at the criminalization of drug use. I mean, we are consistently saying as a public health entity, as healthcare workers, as leaders in the community, that addiction is a disease and that it is a public health problem and that people are in a health crisis. But we as a society are continuing to meet that with a criminal justice response. It's really like divergent messages, right? It's kind of like divergent messaging. Like it's a disease, it's a health problem, but it's also against the law, and somebody could be in jail just for personal use, for just holding personal use, or just having implements, or what we sometimes refer to as paraphernalia. So I think that slowly, I think we are starting to talk about some of that criminalization piece, but that certainly contributes to the stigma. I find that that's a big part of the stigma with healthcare workers. This idea that people don't deserve care because they're breaking the law. So just something for us to think about, I think, as we all move forward. Misconceptions related to drug use, addiction, and treatment that we still find in all communities, but I think we're still finding in some of the rural communities, people who are leaders, like let's say judges in a certain type of drug court, or people who are maybe possibly leading a public health organization or a criminal justice organization, think that there's something wrong with medication-assisted treatment. I sometimes hear people say, well, it's just swapping out one drug for another. So still kind of wrapping around this idea that we're going to control somebody's behavior, or that, we're here to tell them that taking that drug is wrong. So I refer to those as misconceptions because they are. I recently attended the national meeting for HRSA's rural opioid response programs, and there were people there from all over the country. And I was really impressed with HRSA, which is a federal organization, right? That they led the meeting talking about medication-assisted treatment, and they had 3 different people speak, talking about their different choices for treatment and what that meant for their success. And so I think, we are seeing on the national and the federal level a real important discussion about the efficacy of medication-assisted treatment. So I think that is making its way into our individualized communities, but we do still run into some misconceptions related to that. And then, of course, we have provider shortages, all day, every day. We've always are running up against provider shortages. Hopefully, I think COVID-19 has really forced the hands of all of us to engage in digital formats and different types of telemedicine and, things like we're doing today. I'm hoping that we're going to learn some lessons there, and that's going to help us really leverage that knowledge and technology to address some provider shortages out in our far-reaching communities. Transportation continues to be an issue. It's really hard out in when you're in a rural area and things are so spread out. And I know many of you have had these experiences where you're trying to set up transportation for your clients. ruralhealthinfo.org, they have some rural transportation resources that can be effective. And I've got a link to that here at the end of the presentation if people are interested. I do know of one county in Ohio that has had some good experiences with expanding transportation for their medication-assisted treatment clientele with that toolkit. So how do we really build partnerships in rural communities? Again, some of you are already there and you've been there for a while, but I know some of you are really you're seeing your work kind of take you out into a community that maybe you haven't engaged in before. So how do you get there? Who do you want to talk to? I really emphasize that you want to engage all allies. Grassroots harm reductionists are everywhere. I have learned so much about what's going on at the grassroots level in some of our outlying counties in the state of Ohio through my work with Harm Reduction Ohio. And oftentimes, it's, some people that you would just never expect, young women, young men, elderly folks, all people from all different walks of life who have had experiences that have led them to a real commitment to reaching out to people, distributing naloxone, food, those kind of grassroots people. So I'm going to talk a little bit later in the presentation about how you go about, really finding them and engaging with them, because they're very warm and welcome community. You also want to reach out to the medical community, the primary care doctors, health departments, and local hospitals. There certainly can be some stigma and some bias there, but I think that there's also allies there. And sometimes just having 1 or 2 allies in a hospital can open the door for you to be able to go in and present and talk to them about how they can bring HIV testing to their community. Because I think it's important to point out probably that's threaded throughout this discussion, but there are lots of communities that we don't really have HIV testing out there right now. And their local health departments maybe don't have the staff or don't feel like they have the know-how to get started to be in a position to do that testing. So look for allies in the local medical community. Allies in law enforcement and corrections are extremely important. Corrections is a great place to start testing. I know CaraCol has a lot of experience doing a lot of testing here in Hamilton County in our correctional facilities, and I think that's really powerful. And creating those relationships with law enforcement so that we can help people. This is a complex problem. And it's going to take a complex solution. And we're going to need people from all different sectors to come to the table. And also faith-based organizations. People often will ask me about faith or religion when I'm out in the community talking about syringe service programs, for example. And, I don't want to overgeneralize, but here in Southwest Ohio, a lot of the strong faith organizations are Christian. And so, people will ask me questions about, how can I do what I do? What about my faith, or what about being a Christian? And I always really try to remind people that when I think about the teachings of Jesus, I think that Jesus was a harm reductionist. I think about, the Sermon on the Mount, or the sermon that he gives when he returns to Galilee, or even just his relationship and his own, the example that he set with his own life through serving others. And I should say, I'm certainly not a theologian, and I'm not a religious person. Most of what I know about the Bible comes from Jesus Christ Superstar and watching the 10 Commandments in the 80s, as all of us did. But I try to remind folks, but based on those things, I do have what I feel like is some understanding. And I try to remind people that, what am I doing that's so wrong? What am I doing as a harm reductionist that is so different than Christian? I'm meeting people where they are. I'm providing them with what they need today. I'm talking to them about food, housing, safety, their health. And at the end of the day, judgment is not my function. And it's not the function of any of us if we are looking through it through the lens of Christianity. So I think that we can often find some real allies in faith-based organizations. I know that Adam and Billy from here at CaraCol, they created an excellent relationship with Paula at the community church here in Corryville. And so I think that, don't be afraid to reach out to those faith-based organizations, because I think we might have more in common than we think sometimes. And then lastly, is there already a local opioid response group that you can engage with? So some outreach strategies, exploring funding sources to expand your services. You are going to need more money. It takes longer to do everything because things are geographically spread out. People are not densely populated. So it might take you, where as a visiting nurse, I could see when I was working in let's say Walnut Hills or Corryville, I could see maybe 8 people in a day because my clients only lived, a minute or 2 apart. If I'm out working in the rural areas, it might take me all day to see 3 people. And that's important for us, for organizations to remember when we're thinking about how we're going to fund these outreach services. I encourage everybody to look at the HRSA Rural Community Opioid Response Grants. I think that they can be really powerful to kind of give you, what you might need to get what you want to do off the ground. Of course, it's not sustainable funding, but it can lead to more funding. And then, of course, there's state level funding opportunities as well. So, you really want to explore those or have someone in your organization who can spend some time exploring those because you are definitely going to need more resources. You want to see if you can join any community initiatives that are already in place. So many rural communities have consortiums that are already assembled to respond to the opioid crisis, partly because it's been going on for so long. And some of those consortiums are really powerful. Last year in spring, or I guess it was this year. No, it was last year in spring. With being locked down with COVID, all the time kind of runs together. But last year I went out to a rural community in the state of Ohio. They invited me to come out and speak to their consortium about syringe service programs. And when I got there, I was really blown away by the people they had in the room. The room was absolutely packed. They must have had 50 or 60 people there from corrections, law enforcement, recovery. There were nurses there. There were physicians there. The mayor was there. A lot of grassroots folks, people from mental health. So these rural consortiums that are already established can be a great opportunity if you are wanting to get into that community and talk about HIV or start getting some testing going. So, look for those. You can look for those online. And sometimes it just takes a connection with one person to kind of invite you out there. Like for me, there was one person who invited me out there. They contacted me through Harm Reduction Ohio. And then after my presentation, I had about 20 people from that presentation find me on social media. And so now I feel like I have those connections and I can reach out to those folks. So it can be really great. And, and that's part of getting out into the community. Get out there with grassroots groups if you can. Homeless outreach organizations, food pantries. These are people who are actually face-to-face with the clients that we're here to serve. And any opportunity to get out there and get to the people. Of course, it's important for us to get buy-in from stakeholders and to meet with community leaders. But we also have to remember that we want grassroots folks to know that we're there, and we want to see the work that they're already doing and kind of lift that up and become a part of it. Okay, I'm having a little bit of
Tasha, while we're kind of getting this slide deck sorted out, we do have a few questions that have came in if you'd like to take a little Q&A here. So our first question is, do you think that race plays a part in underestimating some of those importances, some of that Maslow's hierarchy that we talked about a little bit earlier?
Do you mean like thinking that because a community is white that they don't have like poverty and drug use? I'll
defer to our question asker. So I'm sorry if I pronounce your name wrong. So yes, our question asker says yes.
Yes, I think so. I think that, I think that's definitely a part of it. I think I know from my own personal experience, when I was a new graduate nurse and I was working in the hospital setting, this was, 15 years ago when we actually admitted people into the hospital for detox. We really don't do that anymore, but we did at that time. And I remember more than once having conversation with someone about the shift I had just had, or, my work and a client that I had interacted with, in a very, general way. And there was always this assumption that the person who was in the hospital because they were detoxing from heroin, there was this underlying assumption that they were Black. And I was like, no. As a matter of fact, at that time, I had probably never had a client that I was caring for with that disease process, with that clinical picture that was Black. But I think we do have some of those like antiquated ideas of, who is using drugs and who is experiencing poverty. And I also think that, so yes, I think race definitely plays a part in that image. And then also because you don't really see it. I think that, when people feel like they see poverty in the city as they're coming and going and they're living their lives and they're doing their thing. But in the rural community, unless you have a reason to be out there, you're not going to see it. I can share with you, I feel like I'm relatively seasoned person. I'm 47 years old. I've been a nurse for a long time. I've done a lot of different things. I've lived, in a lot of different places, traveled the world. The first time I went out to one of the counties in Southwest Ohio to get started on a project that I had been invited to work on, I was overwhelmed by what I saw. I mean, I I mean, people talk about, doing service, going to Africa or going to certain parts of the world. I mean, I felt like I was there. People who didn't have, plumbing, electricity, just really stark poverty. But I don't see that when I'm coming and going to work here at, Christ Hospital or Good Samaritan Hospital. So for some people, it's out of sight, out of mind. That's a good question. Thank you for asking that.
We do have one more question that I do want to get to very quickly here. Just
Sure.
that conversation about treatment that we mentioned earlier, does that include treatment for crack use as well?
Yeah, I mean, meaning that crack use, that it should be included in what we talk. I think that when we're talking to clients about substance use, we let the client lead the conversation. And if my client is using crack, then I need to be prepared to talk to them about the risks that are inherent there. And so what some people say is that we need to stop constantly talking about the opioid crisis, because a lot of people aren't using opioids right now. They might be there, meth is really the trend in a lot of communities for a variety of reasons. But and feel free to put another message into Zoe if I'm not getting at your question exactly. But yeah, I think that whatever we do need to know what type of substance someone is using if they're coming to us and wanting to and they're interested in treatment. And then we really need to have evidence-based treatment options available for them that have a variety of modalities. And what I mean by that is it's not one size fits all. Whether we're talking about crack, meth, heroin, whatever the case might be, there's not one thing that's going to work for every person. And what I personally see in a lot of communities in Ohio is we want to do this one thing. Like, yes, we have a drug court and we're going to offer you medication-assisted treatment, but actually we've signed a partnership with this one drug and this is what we're going to give everybody. We need to move away from that. We need to start stripping some of that down and really moving forward with objectives that are evidence-based. And what the evidence tells us is a variety of modalities need to be offered to every person.
That person did have a quick follow-up that they dropped in the chat. And I'm truthfully not totally sure what they mean here. When discussion, treatment to assist them to use less.
Say it again for me, Zoe.
This person dropped in the chat, when discussion, treatment to assist them to use less. So maybe that's referring to abstinence-only treatment for crack use. I'm not 100% sure.
Yeah, and and I might not be completely knowledgeable either, but I think I get what you might be asking, which is I think that whatever type of treatment is going to be a good fit for that person. I think abstinence only treatment is not ideal for most people right now. It worked pretty well for us with alcohol and some other things for a long time. And it's kind of our societal go-to in a lot of ways, especially when we're talking about like the power structure. But in reality, abstinence-only treatment hasn't really been terribly successful. And what I often say to stakeholders when we're talking about it is, how's that working out for us so far? Last time I looked, things are getting worse and not better. Now we do see success with medication-assisted treatment. Now, of course, that refers to opioid use disorder. I'm not real knowledgeable. It's a little bit outside of my practice area, exactly what types of treatment modalities are used for people and really be effective for people who are using crack cocaine. But I would just say that we do need to be using something that's evidence-based and not just leaning back on an abstinence-only option. And then, of course, at the heart of that is also not kicking people out of programs who may use. Do you have another one for me, Zoe?
There is one more in the chat, but I think that'll be a perfect one to kind of say towards the end.
Okay, great.
Our original person that started that discussion did just want to chime in that crack users will often get jail and not treatment. So
amen to that. That is absolutely true. And if at the heart of your question is the disparity between our societal view of the opioid crisis and the crack crisis, if it's based in systemic racism, I would say hell yes. There's no question about that. We have people who have been arrested for powder cocaine who became the president of the United States, and we have people who were arrested for, a very small amount of crack cocaine that went to jail for, 15 years. So there is no question that we do not respond to that in the same way. I think that we should all be, advocating for that, talking about that. I know that a lot of criminal justice advocates and drug policy reform people who are really pushing to have some of those older laws broken down. But that is a really important point.
Great. Thanks, Tasha.
Absolutely. Thank you, Zoe. So just talking a little bit more about outreach strategies, how do you get into a community that you're not already embedded in or that you've never worked in before? Network with people who are distributing naloxone there now. That can be a really great way to get started. Again, that's putting you in contact with the people that you want to serve. Project On sites that's a great way to connect and find out where those Project On sites are and find out how much naloxone are they given out. I have had some instances where I have gotten in touch with the Project On site and found out and discovered that the naloxone was just kind of sitting there because they weren't really in touch with the community who needed it. So getting that information can be helpful. And then I would say also Harm Reduction Ohio. We distribute a ton of naloxone, all over the state, and have a lot of grassroots people. And even we've received some grant funding in 2019 that's enabled us to even hire some people and pay them to distribute naloxone, harm reduction materials, and educate folks out in the community. So you might be able to whatever county you're really trying to engage with, you might be able to find somebody there through Harm Reduction Ohio. And again, partnering with libraries, churches, community centers, you can volunteer to host a question and answer session. A lot of people might be interested, but they just don't know. They don't know that their community is at risk for HIV. They really haven't thought about HIV in a long time, and they think that we already put that baby to bed. Leveraging social media to identify your partners. Looking at, for example, Harm Reduction Ohio, looking at them on Facebook. A lot of people who are friends with us are grassroots organizations that are distributed all over the state. And here are some examples of those. Ohio Can, Change Addiction Now, the Ross County Recovery Center, Newark Homeless Outreach. Of course, the Harm Reduction Coalition is a great national website for you to find information if you want to distribute flyers, if you want to get some facts together. The CDC has a really great fact sheet on harm reduction also. So really kind of figuring out who's doing that work now and how can I be there with them and kind of engage folks as well. Here's a picture of me and Billy Golden doing some outreach years ago. So this is a nice visual also to let you know, is there a syringe program in Ohio? Most of our syringe programs from their onset include testing. But if you want to kind of get a sense of, what kind of testing is being done in this community, what's going on with HIV, the syringe program can also be a good place to identify allies and see, what's kind of happening there already. But you'll notice there's some real dry spots where we have not been effective so far. But I do have to say, on a positive note, that just 5 years ago, there were just 2 syringe programs in the state of Ohio. And right now there are 21 that are actually up and running, and a couple that have really been trying to get going but haven't officially gotten started. I like to end on this wonderful visual from the Australian Department of Public Health. As many of you know, Australia has really been a global leader in implementing harm reduction services to address HIV for years. And they're really seeing the benefits of it. At this time, they're seeing a decrease in HIV incidence among people who use drugs, HIV and hepatitis C, partly because they have harm reduction embedded throughout their public health system. People can talk to their primary care providers. They can go into clinics. They can use vending machines. They have mobile units. It's a wide variety. And of course, they don't have the issues with access to care that we have just as a system here. But I love this visual. It says $1 that is spent on needle and syringe programs saves $4 in health costs. Now remember, their health care is delivered much cheaper than ours is. So that number would be a lot higher, I think, here. And saves $27 in health cost and lost productivity. I think that's something that we often, as a society, forget to reflect on is, the lost productivity. When somebody becomes, we have a tendency, and part of it is that criminality, that criminalization. We're going to shut you out. Our response to you, you're using drugs, we want you to stop. If you're not going to stop, then we're going to shut you out. And people really become disenfranchised. And the societal cost of disenfranchisement is profound. People are not able to keep a job. They're not paying taxes. They're not able to pay their child support. They're not contributing to the economy. They're not able to care for themselves. And I think that, when we turn our back on that and pretend like we don't see it, it doesn't go away. I mean, we all know that because of the work we do. But in different settings, when you're talking to stakeholders, I think it's important to remind people that, that doesn't go away. The person just becomes worse. And then we see them when they are testing positive for HIV, when they're incarcerated, or when they are coming into the emergency room with osteomyelitis, and they're going to need to receive $100,000 worth of health care. So I think that, getting out there on the front end saves lives and money and just contributes to a more productive society. All right, so let's take a look at our polling questions and see how you guys did on your polling questions. All right, so substance abuse is more common in rural or urban areas. Rural, very good. You guys are so smart. Rural communities have more resources for health and social services. Exactly, that is false. They do not. In rural areas, people who use drugs are less likely to inject, and that is false. At one time, we did believe that to be true, but currently that is not true. We see more injection drug use in rural settings, which has contributed to rural settings becoming what some people are now referring to as the epicenter of HIV crisis in the United States. Non-urban counties in southeastern United States have a higher HIV prevalence than most U.S. cities, and yes, that is true. HIV incidence and prevalence has really blown up in the southeastern rural communities. And there's a lot of reasons for that. And part of it is, access to care and education, of course. All right, great job. All right, here I have some resources. These will be posted. I'll give these over to Caracol to just kind of some links if you're wanting to kind of get started. And again, I know there's a wide variety of knowledge base in the group today. And then my references. Zoe, did you have any questions for me here at the end?
Thanks so much, Tasha. We do have a few questions. I do want to put in one last shameless plug before we turn over to the questions. Please do be sure to fill out your evaluations at the end of today's webinar. When you exit the webinar, the evaluation will pop up in a new window for you through SurveyMonkey. We do greatly appreciate your feedback, as does Tasha.
Absolutely.
So we do have a fantastic question that's been in here since 12:30. I've been sitting on it a little bit since it's such a great question that can spark some discussion. Can you talk about the historic splits in the substance abuse treatment community? Sobriety versus harm reduction, methadone versus Suboxone, and even overdose prevention versus syringe exchange, etc. How do those historic divisions impact our work right now?
That's, well, first of all, how much time do we have? Because we could talk about that all day. That is definitely a great topic and a really important. So let me see if I can break down the question a little bit, talking about, so historically, I think that there has been, historically, there was an idea, we'll take overdose prevention first. Historically, there was this idea that, well, if you give people naloxone and they can just go and get it anytime they want, they're not going to stop using drugs. So again, kind of coming back to that, that controlling behavior mentality, and as a profession, kind of needing to reflect on what our function is or what our role is. So, of course, we all know that we can't really control someone's behavior. Just because they don't have access to naloxone doesn't mean that they're going to stop using. And so there was also this idea that a person is going to need to hit rock bottom. I'm sure all of you have heard this phrase. People really need to hit rock bottom, and you need to let them hit rock bottom. And I think at one time, and I think in some areas you still hear it, it's part of the recovery community too. And, and I don't want to be disrespectful. I think it's important to recognize, I have some friends, some very close friends, who are deeply embedded in the abstinence-only recovery community. And it was very positive for them, and it was very powerful and effective for them. So therefore, that's what they believe in. And I respect that because, that's important. If it worked for you, that's valuable to me, right? But I think what we found with the resurgence of injection drug use and the flooding of prescription opioids and the addictive nature of opioids, that abstinence-only programs just weren't working for everyone. And people were dying at an alarming rate, and we were having increased mortality related to the crisis than we were prepared to deal with. And so that really brought into discussion, medication-assisted treatment, the idea that, who am I to tell someone exactly what they need to do if they feel like they can lead a healthy, productive life and have medication-assisted treatment, then who are we to say that they shouldn't? And if we are, and this is the big thing for me, as professionals, if we are engaged in evidence-based practice, then the evidence leads the way. Not my personal opinion, my brother, he is in NA, and he told me that the only way you can ever get out of it, and I think you still hear that sometimes when we're talking about responding to substance use in our communities. And I always try to redirect myself and others and say, but that's not really what should be leading us. If that worked for your brother, man, that's great. That's awesome. I respect that. I'm not saying we shouldn't be doing that anymore, but that doesn't work for everybody. And we all know that for 2,586 people in the state of Ohio this year, rock bottom was dead. And that's too many for me. One is too many for me. So there's just no reason to see that kind of senseless loss of life. So that's kind of the overdose question. And then to talk about methadone and Suboxone, that is a hot topic. And I might not be fully qualified to really speak on it, but what I will say is I think there's a lot of money wrapped up in there. There's a lot of power, money, and politics. Some of the medication, that was what I was kind of referring to when I said that you'll see some places that say, we're going to do medication assistant, but we're only giving this one medication. And I think that as a nurse, I know that what that is usually about is a really aggressive drug rep or a drug company that's offered you a really good deal if you agree to only use their product. And that that opens up like a whole can of worms that isn't just with medication-assisted treatment, but a lot of pharmaceuticals in America. I really don't like that kind of business, like money business, interfering with what a provider wants to give their patient. So I think we got a little bit of that. Methadone clinics, there's a lot of like ownership and territorialism wrapped up in that practice historically. And I think we've seen some of it break down. We do have different types of medication-assisted treatment now. I remember, and I mean, I'm not that old. I remember not too long ago in my lifetime, people that I knew having to drive to Indiana or to having to drive a great distance to participate. And that was like the only medication-assisted treatment around. So I think we're breaking down those barriers slowly, but they're still there. So to answer the question is, how does it affect us today? It is still with us, and we do still butt up against it. I think that sometimes when I'm with doctors in the rural community, I will hear somebody say, well, I really don't think that people should take one drug and swap it out for another and be on medication-assisted treatment. And that's when I usually take the opportunity to say, in my very polite, diplomatic way, we really shouldn't be leading with our thoughts and opinions. We should be leading with what the evidence tells us. And what the evidence tells us unequivocally is that the best practice for treating substance use disorder is to offer the patient a variety of modalities. And if you're really interested in this also, I would recommend look at the Vermont hub and spoke model, if you haven't already been familiar with that. And they have a fantastic model for how you address substance use disorder in your communities. And we all know Vermont's kind of rural.
Just a little bit roll up there. So I do want to say we have a couple of just comments in the chat. Daryl just wanted to point out that Australians are awesome, just saying.
True that.
And I know Daryl personally, so I don't think he's biased at all in saying that, of course. Judging by the Australian flag background he often has in Zoom meetings. Carly wanted to add that it is a sad reality to have to leverage persons' lives to the fact of saving monies. Also a hard concept to get into play because of our political system being focused on 4 years of work rather than the long-term outcomes that need to be focused on when looking at substance abuse and misuse.
Absolutely.
Thank you for that. So we do have one more question. And I do want to let everyone know that Tasha is going to stay on here for a little bit longer, I do believe, to answer some of our questions. But for those of you who do need to leave us here at 1 o'clock, please feel free to. But we are going to stay on here for a little bit longer with at least one more discussion question. So this one comes from, if you have time, which we just determined we probably do, could you share your thoughts on challenges to engage people of color in many of these programs and services?
Mm-hmm. Well, I think one of the challenges is something that we've all been really focusing on the last few months, which is the systemic racism in criminal justice, corrections, and policing. And I think that when you're trying to engage a community that has been historically harassed, abused, mistreated, and disproportionately arrested, indicted, and incarcerated by that system, when you're trying to engage them, they're going to be hesitant to engage. What research tells us is that people of color are less likely to engage in harm reduction programming out of fear of being harassed by the police or other authorities. I think that's not a blanket statement. I think there's some programs who are probably, real successful in reaching out to certain people in their community. But I think that historically that relationship is certainly one of the reasons why. I think there's also a misconception. I remember when I very first became interested in this work, it was like the early 90s. And, I was reading the New York Times in the library because, it was the 90s. And I guess I did that then. I wasn't like looking at it on my phone, right? And I remember reading this article about harm reduction outreach in Amsterdam. And I remember just being blown away by it. I was relatively young and I wasn't a nurse yet. And I was just like, that is what we should be doing. Going out and engaging people. And so it propelled me to kind of learn a little bit more about some of the work that was being done in Europe and different places in the world. And at that time, you would read things where people would say injection drug use is a primarily white phenomenon. And historically, Black people in America, really don't inject drugs. So I think that, so for a while, and that might have been the trend at different points in time. I think it's ebbed and flowed. But I think with the opioid crisis, as we kind of visualized it on television and in our society, it was all, very white, similar to when we have discussions about HIV, right? When we talk about HIV perceptions in the Black community, a lot of times we have to dig into the historical reality that, when we saw HIV kind of come to, come in front of us on TV, at the very beginning, it was always very white. It had a tendency, the image was often very white. So I think those images kind of stay with us and they create this misconception. And similarly with drug use. So I think it's twofold. I think one, we do have to address the fact that people are less likely to engage with us because they don't trust us. And frankly, they have good reason not to. And two, we have historically had misconceptions about what kind of drug use is being done by what kinds or types of people in our community. And that certainly has contributed to us kind of developing robust programs. And then, of course, I think similarly with systemic racism, we also have fewer people from our end that represent those folks. We should reflect the community we serve, is what we always say in nursing, right? If we reflected the community we serve, our healthcare workforce in Cincinnati would be 48% Black. And that's certainly not the case. So I think that's part of it too.
All right. Thanks so much, Tasha. That is all the questions we have for now. I'll put out one last call for questions. So get to typing quickly while I kind of make our final statement here. Again, please do be sure to fill out your survey that pops up at the end here. We do greatly value your feedback, and that is required for folks that are seeking continuing education credits. And we do hope to see you tomorrow as well, while we're going to continue this discussion about the harm reduction continuum of care at CaraCol.
Awesome. Thank you so much for having me. Wonderful conference from CaraCol.
All right. Thank you all.